Уважаемые коллеги, позвольте открыть параллельную сессию номер 6, которая посвящена чрезвычайно интересной теме миграции, и в частности название этой секции «Управление рисками эпидемии в условиях растущей мобильности населения в современном мире». И, конечно, в общем, актуальность этой темы определяется тем, что в последние годы постоянно возрастает объем миграции, они связаны и с определенными моментами нестабильности в нашем глобальном мире. Количество мигрантов в мире превысило 270 миллионов человек, и вот эти все вопросы мы будем сегодня обсуждать. У нас докладчики из разных стран мира, и позвольте, собственно, открыть эту секцию и представить нашего первого докладчика, представителя Европейского офиса ВОЗ Кристину Мауер-Стендер, руководителя группы страновой поддержки «Ответные меры на чрезвычайные ситуации». И она сделает доклад на тему отслеживания инфекционных заболеваний у беженцев и мигрантов, региональные перспективы. Пожалуйста, Кристина.
And see me, and you can also see my presentation, which should be coming from here.
Мы пока не видим Кристину. Минутку, Кристина. Пожалуйста, вы видите изображение нам?
Can you see my screen?
Вы видите мой экран?
Пожалуйста. Экран нет, мы не видим экран.
Yes, we can.
From our computers.
Вот, теперь мы видим ваш экран. Да,
Okay.
Спасибо.
Now we see your screen.
Thank you very much, and thank you very much for giving me this opportunity to discuss here at this important international conference taking place in Moscow. And as you were saying, Madam Chair, that I will be speaking about how to tackle communicable diseases in the refugee and migrant population from the perspective of WHO European region. And allow me to start with an issue which is close to many of our hearts at the moment globally, and this is the COVID-19 pandemic. So the question I'm posing to myself is, what has been and what is the impact of COVID-19 on international migrants? In 2020, in the last year, we saw very low numbers in arrivals of international migrants because of closures of borders, further restrictions of entrance, and restrictions in general in our countries. And if we compare 2020 to 2016, then we can see that in 2020, only 10% of migrants compared to 2016 arrived to the region. COVID-19 response measures, including lockdowns, border closures, isolation, and quarantine measures, have had a ripple effect on the health of international migrant workers globally. And allow me to indicate some of the economic and social impacts of the COVID-19 related measures in our countries. First, certainly employment status and the income of international labor migrants. The secondly, their legal status. And thirdly, the access to the healthcare services. And all these factors are interrelated to their physical, but also mental health, those of being labor migrants, but also other international migrants, through their access to health services, social determinants of health, such as income, adequate food, shelter, and sanitation. So what are the recommendations for promoting the migrant workers' health during the COVID-19 pandemic, but also in other related or possibly upcoming health emergencies? So first of all, certainly nobody to be left behind. The universal health coverage ensure equitable access to healthcare and health information to all migrants. But also, we know that some migrants and some migrant workers may live in labor accommodations or crowded housing in our region. And therefore, it's important to ensure that employers are adhering to the WHO guidelines for isolation measures which do not violate human rights. We also do know that many undocumented migrants avoid seeking medical attention for fear of registration leading to detention or possibly deportation. And therefore, it's important to ensure the confidentiality of the data and in order to avoid the further marginalization and stigmatization of migrant communities in general. And we also know that stigma can increase the isolation of these groups and impede people from reporting symptoms, seeking medical advice, or testing themselves, which is harmful to both the migrant health, but also to the general population. We also know from all the populations, but also the vulnerable groups, that health promotion messaging and also the risk communication in the context of COVID-19 is crucial. Therefore, we think that it's important to develop the public health communication and risk communication targeting these vulnerable populations like labor migrants, to ensure that there is awareness about what's happening, what help can be sought, but also building the trust and empowering those communities to seek for their advice or help. Last but not least, the health professionals and the health professionals working at the front lines of COVID-19, it is important to empower them and raise even further their capacity to understanding the health-seeking behaviors and access to and use of healthcare services by migrants, by migrant communities, as it is important and crucial for COVID-19 situation, and particularly the case reporting. Some real life examples I wanted to share with you. I'm sure there's many more out there in the European region, but how the countries have taken action to ensure that international migrants and labor migrants are included in their national policies. Allow me to give an example of Ireland. Ireland, who introduced in March 2020 a COVID-19 pandemic unemployment payment that provides financial support to all those people in age group of 18 and 66 who lost their jobs and their income because of the pandemic related to COVID-19. And this policy in Ireland is also including regular as well as irregular migrant workers. So this is Ireland. The other example I wanted to bring to your attention is the more related to the labor migrants and labor migrants, many of them working in the Russian Federation, and particularly the action that Uzbekistan and Kyrgyzstan have taken together a number of partners, to set up a council for assistance to migrants who are labor migrants in the Russian Federation, to make sure that they get the counseling and psychological assistance, possibly also medicines and food if needed in case of isolation during the COVID-19 pandemic. So those are just two examples of many, which we can also discuss later during this panel. Now I come to a topic which is very much at the heart of our discussions and our minds in Europe, but also globally, COVID-19 vaccines and how to ensure that we do ensure the equitable access of vulnerable populations, including international migrants and labor migrants. I think we all agree that it is a tall order to provide a clear direction to ensure equitable access of vulnerable population. But I'm happy to say that some progress has been made. Particularly, WHO's Strategic Advisory Group of experts suggests a tiered system to prioritize who should receive the vaccines. And this expert group advises that low-income migrant workers, as well as irregular migrants, should be defined as a priority group to be allocated the COVID-19 vaccines globally. So they are defined as a priority group to receive the COVID-19 vaccinations if they so wish. Of course, operationalization of that advice and this recommendation is crucial. We do know that there are 92 low and middle income countries globally which are eligible to get the access to COVID-19 vaccines through the Gavi COVAX system. And 51 countries so far, among those 92, have received the vaccines, at least the first shipment of COVID-19 vaccines. Those countries who are part of the COVAX global system have a requirement to have national vaccines deployment plans. And as of March 2021, if we looked at those plans, those national plans, and analyzed those, we know that some of them do include refugees and migrants into their national vaccines deployment plans, but many also don't. And therefore, WHO, in close cooperation with UNHCR, IOM, and UNICEF, is discussing currently at the global level how to advocate and support countries to include international migrants to their national vaccines plans. And even if they have included them, to make sure that we know all those people, those vulnerable population groups in those countries really having the access to vaccines. Making great conditions to vaccines uptakes among those vulnerable population is also absolutely crucial, because we know that particularly regular migrants are afraid to come forward and talk to the authorities and seek for help or receive the vaccines. But also, I think there is a role for the public communication, risk communication, and also role for media to make sure that awareness is there and those people who want to access to the vaccines are able to do that. So this was about the COVID-19, the situation we're living in. I also wanted to briefly touch upon the HIV, and again from the perspective of the WHO European region, and tie this into the international migrants context. You see the chart on that slide on your left side, and this is showing the percentage of cases of foreign origin among total numbers of diagnosed HIV in member states of the European region of WHO. And we know that there is a growing evidence that a significant proportion of refugees and migrants, including those originating from countries with high levels of HIV prevalence, acquire infection after they arrive to the WHO European region. However, we should be mindful of the fact that the region is large, of 53 countries, and there are also large regional differences. For example, if we look at the European Union countries, then 40% of diagnosed cases are migrants, both sub-regional, 40% of diagnosed HIV cases are the migrants. And therefore, we have to be mindful of the fact that we need a sub-regional approach to tackle those sub-regional specificities and differences. We also know that migration can create additional vulnerable situations where infections can occur and spread, and such an exposure to sexual violence, substance abuse, or secondary risk-taking behaviors linked to the poverty or isolation or the marginalization. So therefore, we need to act in a coordinated manner, but at the same time, taking into consideration the regional and sub-regional specificities. Now coming to the TB, tuberculosis, and again, from the perspective of WHO regional, European regional angle. Some data first to set the scene. An estimated 275,000 new and relapsed TB cases occurred in the WHO European region and its countries back in 2017. And this is equivalent to an average incidence of 30 cases per 100,000 population. And this represents, from a global perspective, around 2.8% of the total burden of TB in the world. There is also substantial disparity in the burden of TB among WHO European region member states. And we know that around 85% of all incidents in TB occur in 18 high priority countries out of 53 in the WHO European region. We also know that foreign-born individuals make up about 8% of all TB notifications in the region, but the proportion varies quite substantially geographically. Migrants in Europe experience a disproportionate burden of MDR TB compared to non-migrant populations, but little so far is known about the burden of MDR TB in specific migrant groups, including refugees. And we also know that there are twice as many males as females reported among all incidents of TB cases in the region. And now a few words about the migration and TB to add to my previous slides. Migrants may have high risks of becoming infected or developing TB depending on their incidence of TB in their country of origin, but also the conditions in which they travel, and of course also the living and working conditions in a country of immigration, their access to health services and to the social protection. TB is very rarely transmitted from migrant population to the resident population due to its low infectiousness and the limited social mixing of two populations. And I'm happy to say that WHO European region is the only region in the world with consensus documents on the minimal package of cross-border TB control and care interventions. And this basically means that the package ensures the access of medical services, irrespective of the migrant's registration status and non-deportation policy until intensive TB treatment has been completed. And last but not least, as I'm working for the WHO Region Office for Europe, and one of my responsibilities is also the Migration and Health Program. So what do we do and how we can help countries? I think there are three key words which I'm happy to elaborate on later on. One is that we're producing the knowledge and evidence on migration and health to support countries to make better policies and inclusive policies. We are also supporting countries on bilateral basis to make sure that those policies are based on international recommendations, international regulations, but also how to best implement those policies and how we can learn from each other and make sure that there is a solidarity in terms of lessons learned. And then last, we're also working quite a bit on general information and advocacy area related to migration and health within the WHO, but also certainly towards our member states, the 53 countries in the WHO European region. And I would like to thank you and thank you for your attention, and happy to take any questions at a later stage of this panel. Thank you.
Большое спасибо, Кристина.
Thank you, Kristina. Let me ask you one question. Let me clarify which proportion of HIV-positive migrants has already come to the countries of the European regions with HIV. You have already dwelled upon it, and I couldn't understand these indicators.
Okay, so maybe what I can do is I can share my presentation again, just to put up the slide which was related.
Просто достаточно, если вы...
It's enough to tell us the proportion. How many of them? 40% or 20%? I couldn't understand it accurately.
So what I was saying, and sorry not to be clear enough, is that what I was saying, that I think the European region is large. It's 53 countries, And we have a big disparities there. In terms of the European Union, which was one of the examples I gave, the European Union countries, 27 countries, if we look into those countries in as a group, we know that 40% of HIV diagnosed cases are coming from migrants. So 40%, which is very, very high in that particular sub-region of the WHO European region. I hope I did answer to the question.
Да, спасибо.
Yes, thank you very much, Kristina. Maybe some other questions will also be related to you. You are ready to ask your questions, and at the end of the session, we'll try to answer these questions. And now let me give the floor to another speaker, our esteemed Davron Mukhamadiev, the coordinator on healthcare in the European region, the International Federation of the Red Cross Society and Red Crescent Society. I am happy to see you, Davron, here at the conference, and now we give you the floor. And the topic of your presentation is health and legal barriers on access of different categories of displaced people to health services in the Europe region. Thank you very much, dear organizers of the conference. Natalia, thank you very much. I am delighted to see you. Fortunately, we will also see one another in person. Let me represent our recently conducted survey findings and the key issues on medical and legal aspects of the barriers to access of different categories of displaced people in the European region. First and foremost, let me provide an overview of the migration situation and provide the key data of the situation and the corresponding summary based on this study. The last massive displacement of the population to the territory of the European region was initiated in 2015-2016. Over the past 5-6 years, we have formed this flow of migrants. It is related to transportation of the population from the Middle East region via some channels, via Turkey, Greece, Italy, and Spain, and also the Russian Federation to the Western countries. Let me say that the trend of migrational situation is not represented in the CIS countries, but I reported on it at the last conference. I will just refer to these studies. Let me start from the fact that according to the mandates and the activity of the Red Cross and Red Crescent in the domain of migrant health, we pay special attention to responding to emergency vital needs of the migrants and the needs of health, and we provide necessary medical aid in the access of basic services, in sanitary and education of migrants, and also first aid and psychosocial support. Also, our mission is promotion and protection of migrant interests. We provide them with access to healthcare services, dwelling upon eradication of any forms of stigmatization and discrimination of migrants. The findings of this study are represented. It was conducted by the Institution of Development of Management of Healthcare, and which is cooperating with the WHO Center on the Health of Migrants. We can see large scientific institutions which are dwelling upon the health of migrants. It was conducted in close cooperation with the Society of the Red Cross, Bosnia and Herzegovina, Northern Macedonia, Montenegro, Serbia, and it was supported by our partners and the Red Cross. The key goals of this study included receiving scientifically substantiated data on the access of migrants to medical services and the chance of using them, the level of medical literacy of the migrants compared to in the system of healthcare in the country where they're located. We are also going to define the key challenges related to healthcare and to get the data on specific needs of different groups of population, such as women, people with disabilities, and elderly migrants. The methodology of this study was the following. Our methodological basis was presented by scientific institutions of the Red Cross. We conducted surveys aimed at both migrants and the employees of the organizations working with migrants in each country. We've interviewed 150 migrants and 120 employees of various governmental organizations and international agencies, such as the Red Cross, the International Organization on Migration, and the Great Commissioner on the Refugees in the UN. The study period lasted from March till July 2020. It was long-term. We can see the topicality related to the vulnerability of migrants and the vulnerability related to the 2020 COVID pandemic. We will also develop on these issues. We have analyzed 20 indicators on various aspects, such as health condition of migrants, prevention of communicable diseases, traumas, mental diseases, immunization and vaccination, which is of prime importance nowadays, and also access to the public healthcare system. It is impossible to cover all the results of this study, but you can see the links here and you can familiarize yourselves with these details of the presentation. As for demographic indicators, the average age of migrants, and most of them were examined. They were aged 18, 20, 19. They are rather active, and some of them were aged 30, 39. Most of them were men. They were not married. They didn't have children, apart from a few of them, and most of them were Muslims, but only a few of them were Christians and representatives of other religions. There were also representatives of Africa, Asia, Middle East, Central America. As for the self-esteem of the health condition of migrants, we highlight that most of them felt either extremely good, such in 39% cases, or good in 12%. Most of them believe that their health condition is satisfactory. As for chronic diseases, most of them marked arterial hypertension, rhinitis, eczema, dermatitis. Mental diseases and disorders were of prime importance for migrants. Chronic anxiety, chronic depression. This aspect was of paramount importance. Also, let me highlight the regularity of medical examinations. Most of the surveyed people underlined that they had undergone the medical examination right after arrival in 48 hours or over the first week upon arrival, and a few of them mentioned that they had undergone the medical examination more than 3 weeks later after the arrival. As for the organizations which conducted medical examination on arrival to in the country, you can see the differences in different countries. In the lower slide, most of them noted that the representatives of non-governmental organizations were provided by medical examination. 56% of people. In Montenegro, 90% of migrants underwent medical examinations conducted by local healthcare organizations in such countries as Macedonia, Serbia, and Bosnia and Herzegovina. We can see the representatives of international agencies. And another important issue is awareness of migrants of communicable diseases which are prevailing in Europe. Almost all of them answered that they were aware of communicable diseases. More than 33% of people noted it. 53% were not aware of it, and 25% were partly aware. You are able to see this chart. I will not elaborate on the details. Now let me move on to the awareness of key symptoms of communicable diseases. A very good and fair knowledge of key symptoms was demonstrated by 50% of the respondents, and a little bit fewer people showed lacking knowledge in terms of awareness of key symptoms of infectious diseases. Here are the measures on prevention of communicable diseases. Over 46% of interviewed migrants said that they were aware of prevention of infectious diseases. In the course of the study, which is rather satisfactory for us, the profile of awareness and education of migrants is improving. A few years ago, we conducted a study in the Russian Federation. This percentage was a little bit lower. According to Russian studies and our current experience, the awareness of the migrants on prevention of infectious diseases is also improving. As for the examined migrants, few of them were women. Some of them were women and others were men. And women were asked about the accessibility of preterm care, antenatal care, because most of them were either pregnant or on this stage, and only 2 of them said that they had access to antenatal care, and 4 of them said that they did not have any access to antenatal care, which is an insufficient factor. This slide demonstrates the information received from the representatives of international organizations. It was assessed on provision of medical assistance to migrants. You see that in 41% of cases, medical aid was provided by the representatives of international agencies or humanitarian organizations. In 37% of cases, it was the government which provided this assistance, and in 23% of cases, it was provided by intergovernmental organizations. This aspect is related to provision of medical assistance, and the lower slide shows the activity of migrants while benefiting from these services. The migrants from Afghanistan were the most active ones because they took advantage of the services available. Some other migrants descended from either Pakistan or Morocco, and Syrian, Algerian, and Iran migrants were not that active. They did not refer to medical institutions. That's actually only when they received the suggestion of the representatives of medical entities, they could refer to the medical institutions. As for awareness of migrants in immunization, this issue was included in the list of before the pandemic. The awareness of migrants on national immunization protocol for the host population is rather high. Vast majority of the migrants, 40 to 52%, were fully aware of immunization issues. And this slide also shows on the right side that most of them, 50 to 69%, highlighted the importance of these events according to the immunization calendar. and they were also ready to be vaccinated. They know that the vaccine is very effective and an economically viable tool on overcoming the infection. It has already been mentioned in the previous presentation of my colleague from the WHO. It is important to include migrants in such events. It is of prime importance from the psychological point of view and from the point of view of perception of the need of immunization and vaccination. Which barriers exist and which of them was identified? I mean, psychological barriers and some other barriers, and some of them are common in other countries. There's a linguistic barrier which is of prime importance, while receiving access to medical services and medical knowledge of migrants. In this case, 33% of migrants spoke only one foreign language, and 35% of migrants did not speak any language apart from their mother tongue. In 21% of cases, migrants could speak more than 2 foreign languages, or 11% of migrants spoke 3 or more foreign languages. Our Society of the Red Cross attracts such migrants in order to provide communication with migration communities. They are volunteers on dissemination of knowledge and education of migrants. Another key aspect of the barriers was the amendments in the legislation and the policy in 2015. More than 35% of migrants said that in these 4 countries compared to 2015, the policy and the legal approach to migrants were improved. Some of the migrants use almost the same services of healthcare as the local population does in terms of COVID-19 vaccination. We can see the recent data. Some of the countries included the migrants in their vaccination plans, which is really great. Let me also outline migration and COVID-19. Kristina has already dwelled upon it. Still, from our point of view, migrants, including other categories of displaced people, such as the ones who are asylum seekers, were affected by the pandemic in terms of healthcare and the social and economic factors. The migrants who are on the way to the study and the ones who are placed here need either international protection or legal status. They are especially vulnerable. Due to the governmental measures implemented in the course of COVID-19 in terms of limitation on displacement, they negatively affect the health of migrants. Invariably, their anxious condition and their health problems is caused by lacking access to healthcare services, and they do not also have any access to food and other resources which exacerbate their health condition, and the legal limitations also exclude them out of national plans of vaccination, which worsens the health of foreign people. You can see that our attitude to foreigners is changing during the pandemic, and the negativization of this approach is of prime importance in terms of general atmosphere and access to healthcare services. As for the key summary and recommendations, let me highlight that our migrants have a limited access to the services of healthcare, and this situation was exacerbated by the pandemic. the migrants are not fully aware of their health condition and the preventive measures in terms of communicable and non-communicable chronic diseases, although this situation is changing for good. Linguistic barriers may be considered as the most significant ones in the access to healthcare. Sanitary enlightenment and outreach of healthy lifestyle is crucial to migrants and refugees. Unfortunately, let me highlight that no short-term and mid-term and long-term decisions of improving the health of migrants take place. I mean, the Red Cross and some other agencies which are now supporting the vital needs of the most vulnerable migrants. Another important issue is the fact that this scientific research allows us to renew the dialogue with the stakeholders, with the public entities in terms of decision-making on long-term tools and amendments to the legislation in terms of access to healthcare services. In terms of migrants, here you can see the quotations of the migrants. They said that when they were interviewed, there are some preferences on the information in the mother tongue. You can see the quotation that the police didn't allow them to stay with their children in the camps. The Iraqi women from Northern Macedonia said, some Iraqi migrants said that they wanted to get better humanitarian assistance of the government, and also the presence of interpreters was crucial in medical assistance, and the migrant of Morocco required more information and more points on medical assistance. They reiterate the importance of this medical aid. I have already highlighted that the organizations of the Red Cross and the Red Crescent do their utmost. Let me highlight that some interesting studies and initiatives are undertaken by us in the Balkanic countries and some other parts of the European region. You can see curious models in Denmark when the Danish Red Cross has organized 2 clinics when the medical aid is provided to migrants voluntarily. The RF is another interesting example of providing treatment of HIV displaced people in Ukraine, and there are also some initiatives on economic estimations of accessibility of the system and the services of healthcare. The RF has also conducted some interesting activities. Economic estimations on deportation and public spending related to health condition exceed the expenditure which could emerge if this public government had sent to the healthcare of migrants. These topics are interrelated despite various geographical contexts of our studies. They testify to the fact that we need long-term solutions and the participation of the government in terms of medical aid to different kinds of migrants. Thank you for your attention. Let me finish my presentation. If you have some questions, don't hesitate to ask them.
Thank you, Davron, for your wonderful presentation. You indeed represent the organization which spares no effort as to contributing to the health of migrants and taking care of them. And you are very emotionally involved, as well as the brilliant expert. And I do hope that at the end of the section, we're supposed to have some questions to come. Please do not exceed your time limit for the presentation. We have another 3 speakers to come. And the next speaker represents the organization of the Red Cross and the Red Crescent, and he is the General Secretary of Syria, Erksoussi Khaled, and he is going to present a very interesting presentation on the involvement of the population and the public healthcare system from Syria. And he was involved in some certain situations due to the military conflict, and he was dealing with quite a number of displaced people and migrants and all the problems pertaining. Thank you so much.
Thank you. Good day to you from Damascus. Of course,
не видим ваши слайды.
as you know, the Syria crisis has been there here for 10 years, and the Syrian Red Crescent is the lead humanitarian agency in responding to this crisis. It is known globally the correlation between migration, displacement of population, and public health, and considering the importance of containing the risks of global emerging diseases. The fact that it poses significant source of concern that has raised the attention of infectious diseases and emerging new ones. Here we should mention the great efforts that has been made worldwide to combat many infectious diseases such as malaria, AIDS, plague, Ebola, cholera, and others. The process of migration and population movement constitute a major challenge for global public health. It is one of the factors that cause the spread of infectious diseases between countries and societies. And from here, it becomes clear the need for cooperation and development of multi-level, multi-party policies to overcome those challenges. The migrants may suffer from diseases or symptoms different from those suffered from by resident population. Likewise, conflicts and crises have pushed a large number of people to internal and external migration. As a result of this, the transmission of many infectious diseases, as well as the emergence of mutations of those diseases that might be more deadly, have longer duration and worse impact on the society. It is worth mentioning some of the practices that helped us, of course, also reduce and prevent the transmission of diseases as a result of migration and population movement, internal population movement. Examination of migrants or internally displaced persons at border points and places of gathering and documenting those results. Triage of infected cases and determining their severity. Providing necessary medical services, including referral to hospitals. Apply isolation and quarantine as needed. The Syrian Arab Red Crescent, SARC, has participated in many humanitarian responses during the past 10 years of the Syria crisis, evacuating people from hard-to-reach areas to shelter centers, where various services have been provided, including medical services. We mentioned, for example, the response of Eastern Ghouta near Damascus that happened 2 years ago, where the number of people exiting from Eastern Ghouta to shelters was around 150,000 people who exited during 1 week. And the response our response to this was through provisioning of many services. For example, preparing shelters to receive displaced, where accommodation rooms and communal kitchens were equipped, preparing the Watson network, water and sanitation network, securing bathing and drinking water, implementing health promotion activities, including implementing insect and rodent control activities, with the aim of limiting the transmission of and outbreaks of epidemics. Provide food and food parcels and ready-to-eat food parcels in order to enhance immunity and maintain health. Secure medical services of primary health care, such as minor surgeries, psychological support, mental health, physical therapy and mobility aids, and nutrition support through the establishment of 3 medical health clinics and assigning 10 mobile clinics daily with 25 ambulances, and they've trained teams, the recruitment of medical personnel such as doctors, pharmacists, and nurses to work on daily basis, as well as volunteers to provide psychological support and community health during the period of more than 2 months, where those people remained in those shelters. And after those 2 months, they moved back to Eastern Ghouta when the conflict in that area was over. Through the documentation of disease cases, many non-communicable diseases have been observed, such as chronic heart diseases, stress, diabetes, cancer, and others, as well as infectious communicable diseases such as diarrhea, hepatitis, and blood-borne diseases and AIDS, in addition to fractures, wounds, and burns. All cases have been dealt with, and the ones that require treatment have been referred to hospitals, resulting the number of medical services provided reached 415,000 services in those 2 months. Likewise, the response in Homs, also the same situation. Medical services were provided for 10 days, 36,000 medical services. The response in Dar'a in the south of Syria, also for 40 days of population movement, 16,000 services. And finally, in Aleppo, there was also medical services provided during the months of population movement, which reached 51,000 services. In its multi-sector emergency response, the Syrian Arab Red Crescent have attached great importance to health sector, especially services provided to the displaced population, with the aim of limiting the spread of diseases among the displaced, as well as preventing the spread of those diseases in host communities and reducing mortality rates. Syrian Arab Red Crescent plays an important role in helping the health authorities in the country to strengthen and improve the health and public health sector all over Syria through securing diversified medical services to reduce infectious and non-infectious diseases, disability rates, and support mental health, as well as participating in the surveillance of emerging and renewable health threats. Today, the whole world suffers from health, social, and economical impact of COVID-19 pandemic, and Syria is one of those affected countries. As the epidemic has greatly contributed to the increase in the burdens already resulting from 10 years of crisis in Syria, and many restrictive measures and sanctions imposed on Syria. That is affecting our humanitarian work in many aspects. Since the start of COVID-19 epidemic in Syria, the Syrian Arab Red Crescent sought to take necessary measures and carry out activities that contribute to preventing the spread of the epidemic and mitigating its effects at various levels. So support is needed in terms of vaccines and for the health system in general, so we can overcome the challenges and provide health to the people in need all over Syria. Thank you.
Большое спасибо.
Thank you so much. It's a very appealing experience of yours, and the scale of this aid provided is very, very surprising. And thank you for your contribution. We do realize that it is really a really painstaking issue. It's really hard for all the migrants. And once in 3 months, migrants may come to one country, then get back to their motherland. It's a principally different configuration of our sort of migration as opposed to the Syrian situation. And indeed, you have a very serious problems with migration. Thank you so much. I hope our audience will put some questions later at the very end of our section's deliberation. And now I would like to give the floor to Natalia Sapozhnikova. She is the head of the clinics of the Diagnostic Laboratory of the Moscow R&D Center for Dermatology and Cosmetology. And she's going to talk about the expertise and findings of this particular entity. Natalia Alexandrovna.
Good afternoon, dear colleagues. Let me express my gratitude to the organizers for the invitation to this conference. We have been participating in similar conferences exclusively online. It is the first in-person conference for me. It is a true pleasure because we can see the prospects for the future. The topic of my presentation is the experience of examining labor migrants for HIV and syphilis in Moscow. Labor migration is a typical process for many world countries. The labor flow of migrants constitute the labor reserves for industrial enterprises of many countries, for transport, for different services, for construction. Russia is not an exception to this rule. On an annual basis, over 10 million migrants cross the borders of the RF. The particularity of the labor flow is the following. The migrants arrive in Russia from unfavorable regions from the ideological point of view. I mean, the previous republics of the Soviet Union. Thus, the federal law was enacted in 2002, number 115, about the legal status of foreigners in the RF. This law stipulates the goals and the order of providing the documents for temporary residence, patents, and the permits to working in the RF. When the migrants are examined for different communicable diseases, which are hazardous for others, which may be the reason for giving the temporary permits for living in these regions. And if the results are good, if the test values are positives, they are allowed to work in the RF according to the results of HIV examination. The migrants receive the certificates on absence of HIV, and then they go to a psychiatrist and to a narcologist. Here you can see the number of granted documents and the structure and the dynamics, which was initiated in 2012, and it was finished in 2019. Until 2015, the migrants were examined by commercial medical institutions, and only in 2015 a new building was erected. Its useful area is over 50,000 square meters. 7,500 people may be here during the shift, and it is divided into convenient areas, and it spans the area of one window. 185 windows where they're serviced for 10 minutes. The documents are received from the migrants, and then they apply for patents and for notary translation force. And then the medical insurance is provided to them. There is also a bank zone where 70 operational terminals of service are provided, and they are serviced for 8 minutes. A dactyloscopy zone includes 92 workplaces, and they are serviced for 5 minutes. They are checked in the database. A dactyloscopy of 10 fingers, of palms, and also the photo of them is provided. And there is also a testing zone encompassing 445 workplaces. The exam on the knowledge of the history of Russia and the Russian language and the legislation of the RF is conducted there. The medical area is part of our branch. It is the multi-purpose Medical Center of Labor Migration. This branch is part of the Center of Dermatology and Cosmetology. It is represented by 175 cabinets, and the time for examination is up to 30 minutes. If all the stages have been overcome, the migrants receive patents and permission to work. Our medical center is including these spacious halls, which allows us to follow social distancing during the pandemic, and the migrants are serviced in a high-quality fashion. The branch of the multifunctional medical center of labor migration carries out medical examination for infections which are hazardous for others, such as syphilis, HIV, tuberculosis, and they're also tested for drugs. It is the only organization in Moscow. It is allowed to carry out medical examination of foreign people in order to grant patents for work. You can see these premises on the slide. Over 12,000 square meters is occupied by this center. It includes 175 of cabinets, including the collection of biomaterials for drugs, such as urine, and there's also an express laboratory in this area. There are 33 cabinets of dermatology, fluorography cabinets. There are 31 of them. Migrants are examined by 50 physiators, 35 narcologists, and there are also 18 cabinets of blood test collections. Since May 2016, the center has organized its own laboratory, which enables it to decrease the time of the examination up to 24 hours. Which diseases are hazardous for others, and which diseases are tested. They are tuberculosis, syphilis, HIV infection, lepra, and COVID-19 since 2020. Screening tests for HIV and syphilis for migrants are carried out by the immune fermented method in IFA analyzers produced by Tican, Austria. The tests for syphilis and HIV infection are conducted by immune blotting method, and special experts are involved. This slide shows the algorithm of medical examination, which was devised in 2020. The migrants spend only 1 minute at the reception, then they are tested for drugs in urine. It takes 2 to 3 minutes. Then they are going to a dermatologist or a dermatologist. They are referred to fluorography if there is a suspected case of some changes in lungs. A physiater and a rentgenologist and a radiologist communicate with the migrants, and they decide whether the migrants need a smear for these diseases and the microbacteria of tuberculosis are needed or not. A psychiatrist and the narcologist are also examining the migrants. Till 2020, we didn't take a smear for COVID-19. Now we take it, and the blood collection takes approximately 5 minutes for HIV infection and for syphilis. If it is required, there is also a smear of the nose for lepra if it is suspected. The medical part of this center also includes some treatment rooms which are dedicated to vaccination, the vaccination from measles and seasonal influenza. Infection doctor also communicates with migrants, and this time from the reception to test collection takes 40-45 minutes in total. This slide shows the algorithm of this study for syphilis. Syphilis screening is carried out by IFA tests. Total antibodies are determined. MG antibodies are also identified if needed. When they receive positive results in the laboratory of the center, immunoblot is conducted, and it is possible in severe cases. There are also some cases of late syphilis and history of syphilis. Thus, we use the tests of pale trypanemia and fluorescence reactions. They are conducted in our laboratories free of charge. It is the responsibility of the center. When patients are diagnosed with syphilis, they are receiving treatment, but they may refuse to get treatment. Otherwise, they will undergo deportation. But if they agree, we examine them once again, and the migrants may, with the patients with the syphilis history, can receive a permission to work and a patent. The algorithm of study for HIV infection is different. Screening includes immune enzyme analysis, the repeated study, and the confirming tests in immunoblotting. If a positive test for HIV is confirmed, the patient undergoes a deportation out of the RF, and it is also typical of tuberculosis cases. The CT is conducted as well as PCR. If the results are positive and the diagnosis is in the migrants, they are deported. The Center of Dermatology and Cosmetology is the only organization in Moscow to be entitled to carry out medical examination of citizens in order to issue the patents and the permission to work. Only 7% of these migrants are examined in the private system of healthcare. It is not that good, but everyone has the right to make choice. After the transition of the examinations of foreigners to the public sector of healthcare, we witness a significant increase in identification of infectious diseases. 2.5 more cases of syphilis were identified. In 2018, we observed the full-scale flow of migrants. 1,634 cases of syphilis were diagnosed in foreigners, which is 0.33% of the ones who were examined in the migrational center, and 51% in the general structure of syphilis registered in Moscow. These patterns of tuberculosis were the following. In 2018, 462 cases of tuberculosis were diagnosed in foreigners, which is 0.08% of the examined, and 14.03% in the structure of tuberculosis registered in Moscow. There were 422 cases of HIV infection cases. I dwell upon 2018 in order to understand what is happening right now. We can see the medical examination of foreigners over the last 3 years. The number of migrant flows were limited in the end of 2019, and the flow of migrants was a little bit lower. 497,000 migrants were examined in 2019. 1,164 cases of syphilis were diagnosed. There were also 478 cases of syphilis and 332 cases of HIV infection, and we also started examining the migrants, testing the migrants for COVID-19. These numbers are hefty. In 53,495 migrants, 1,451 migrants were diagnosed with COVID-19, and 181 migrants were HIV infected. The flow was limited. At the end of the year, they extended, and the borders were opened on the 1st of April. Still, the morbidity is rather high. HIV infections and syphilis are part of history of many patients. There's a 1.2 ratio. When we see the history of syphilis, we can see 23,000 people. And on the 19th of April, we could see large COVID figures, whereas the morbidity of HIV and AIDS was insignificant, and as well as tuberculosis. To sum up, let me highlight that the effective modern organizational model of medical examination of labor migrants was implemented in Moscow. And the creation of this branch of the Multifunctional Medical Center of Labor Migration on the basis of the medical institution of the public property form allowed us to significantly reinforce the governmental control over diagnosis of syphilis, HIV infection, and tuberculosis in Moscow. Thank you very much for your attention. Thank you for having me.
Thank you. Thank you, Natalia Alexandrovna. I'm very impressed with your space and nice-looking premises. I have some personal questions to you. What is the procedure in identification of COVID-19 at the level of migrants? We do realize that HIV presupposes deportation, and we know that procedure. And some treatment may be provided. But as to TB and COVID, the question arises, what is the epidemiological threat we are posing? TB and HIV are chronic diseases, and as to the load onto the Moscow-based hospitals, it's hard for us to do. But as to COVID-19, infectionists are fully in charge of that, and they have the same algorithm as for the locals, and same to migrants. They offer, hospitalization, first aid, ambulance, and the migrants have an access to all these services. All those coming to the city, and actually all of them are eligible for the medical aid, for the emergency, and it is provided on a full-fledged basis. It is on a free of charge basis, the way it is provided, but some services could be payable, but hospitalization plus treatment is all done on a free of charge basis as the emergency aid measures. So the numbers are high, and all these people were provided with a highly qualified assistance with a very good result. I haven't heard anything as to the mortality, and everything looks more or less okay. And my last question, what is the cost of this full package of services? Within 24 hours, the migrant may be given the results of his medical examination. And the load on diagnostics for COVID-19 has been taken by us, and the migrants never paid any copy. I mean, I am talking about the full package. It's 10,000 rubles as the full medical examination. They get a patent. No, this is our own money. It is 10,000 rubles less COVID, and this is the burden we've assumed on our shoulders, and this is a part of the free of charge service if the regular procedure is rendered. And we may somehow, without any trading or bargaining, assume this responsibility. Nobody knows what will be going on in the future, as our budget is somewhat meager. Probably the situation will change, but this is how it goes nowadays. Thank you for your very interesting presentation. Maybe some other questions will come. It's 50 plus 50. I've never seen anything of that sort in the past. And our last speaker is Irina Gennadievna Kostetskaya. She represents the organization which she was involved in the organization of our event, and they are working very effectively in the East European countries. And she's going to talk about the mobile clinics and providing medical services. She represents Full Speed InfoSves, the deputy director. Dear colleagues, my mission today is to talk about our Russian program for technical aid, for technical assistance in aid and other infectious diseases, and also rendering the assistance to migrants when they have to get back to their families. And also we provide the same assistance to their families as well. And our key objective was to enhance the capabilities for testing the infections of HIV, AIDS, and syphilis for people who live far away from the medical institutions where those tests could be taken. And when we planned our project activities, we had two ways to choose. First and foremost, to organize the mobile teams for testing. We had to be fully dedicated, justified, and we've attained our key goal, and the integration of services on the free of charge basis for testing HIV, syphilis, hepatitis, and other diseases. And every person is to be given a chance to be subject to such testing, those prone to higher risks of those diseases. And these mobile clinics haven't been yet seen by the majority of our audience. And this is how it looks like, those mobile clinics. We have three sections. One is a lab. We use express tests, and two more rooms are attractors. They attract the attention of people to us. This is the functional diagnostics room, and people are provided ultrasound diagnostics. Also, they may visit the general practice therapists, and hygienic services to be provided. 70% is the share of women. When such mobile clinic comes to some rural areas, men are normally are in migration, and their family is at home. And gynecological room attracts the attention of many women, and the majority of them visit this particular room. Originally, they do not even think about any kind of tests, and thus they are involved into our testing program. And in addition, the result we've acquired as of the mobile clinics is the assistance to the primary link in the healthcare chain. And in the majority of the countries, primary aid is provided. This medical prevention examination. We have more mobile clinics in Kyrgyzstan, but it couldn't be 100% covered, as within a year period, we are not able to visit all the residential areas and cover the local population. But year over year, the number of mobile clinics is growing. As to Tajikistan, and we want to show you the scale of our efforts, more than 240,000 patients were covered, and 87,000 were tested for HIV. And what do we mean by that? The tests for other infections look more or less the same, but originally we offer the tests for 4 types of infections, and people may come specifically to be tested for hepatitis, as it is a very popular disease, and whole families come with the intention to be tested this way. As to Armenia, more than 38,000 people were covered by these services, and 47,000 were HIV tested. And Armenia is focused on the testing of the maximum number of people, in addition to providing other services, medical services. But the availability of the mobile clinic and additional services make it very attractive for the labor migrants. And in addition, we had more than 700 tests provided for coronavirus antibodies, and we resort to these tests nowadays. Well, and I'm going to develop on it later in more detail. And the medical teams are to be tested, as well as the patients having high temperature, fever, and other complaints, and they are tested just separately in a special room for paramedics, or in the local administration, having the mobile clinic nearby, so that these people could not be invited onto this mobile clinic. And as to Kyrgyzstan, more than 257,000 are covered. 78 plus thousand were tested for HIV, and as to COVID antibodies test, it encompasses 3,500. And the clinics, the clinic of ours was placed at the border of one of the regions of Kyrgyzstan. We provided the PCR tests, and those coming into the this region were subject to such tests. But it turned to be a very costly one, costly for the budget, as we found out later. And these are some general statistics as to how many people were covered by the mobile clinics, how many people were tested for 4 types of infections. And in 2020, we're supposed to have a decline related to lockdown and some bans, and just some curbing of some activities due to the pandemic. And the local press tried to persuade people that you'd rather not go to the medical clinic or outpatient clinic at the times of pandemic. But within the 2 months period, this trend somehow faded out, and the people do not say no to the medical assistance, especially tests are provided comprehensively with other services. As to COVID, we had to impose the anti-epidemic mode. In our mobile clinic, we had some special disinfectants, and we also used a series of tests. And additionally, we supplied the personnel with the PPE as well as patients, and it was done within the framework of our program and also partially at the expense of the budget. And also, it was provided by the hospitals, outpatient clinics. And the informational material for the patients was also disseminated in Tajikistan. And thus, we've managed to create some pertinent conditions for mobile clinics to go on working. And this is the prime information which I wanted to highlight. And indeed, we highly evaluated the role of the mobile clinics for the system of healthcare, and we will find some follow-up of this endeavor in other projects of ours, and it is supported by the European Fund for Stabilization and Development, and 4 medical modules will be involved in that project, and therefore we will provide the full-fledged preventive medical examination and also overall medical examination as well.
This experience is totally positive, and hopefully it will not finish when we complete our project. It was a pleasure to see the experts who are working in these clinics. We have finalized our agenda, and now we have several minutes for a Q&A session. And dear colleagues, you may now ask your questions to the speakers. Are there any questions? Okay. Let me address again. I don't know.
В городе Москве или к вам?
I don't know. As for this program, we are now implementing the 3rd phase of the program. Maybe it will be prolonged. This issue was discussed at the coordination committee. There will be some interdepartmental consultations between the Ministry of Foreign Affairs, the Ministry of Finance, Rospotrebnadzor, and the Department of Health. They will decide whether this program will be extended or not. Still, we need the requests from other countries, and they were enumerated today. All the countries, 4 countries were represented, and all of them expressed their willingness to extend this program. This activity of mobile units and clinics is beneficial. People are going to extend the coverage by extra mobile clinics. It was said by the representative of Tajikistan that only 70% of the population of hard-to-reach regions may be covered, and 30% cannot be achieved because these districts are really remote. They are far from mobile clinics, and 1 or 2 mobile clinics are required in Tajikistan. Hopefully, this issue will be reviewed in a positive way. And we also have the last question. Maybe any questions? No questions. Thank you very much. Thank you, dear speakers, for your great presentations. Thank you, dear participants of our conference. There are many of you who are listening to us online and offline. See you in other sessions. Thank you very much.
Большое спасибо.
Thank you very much. Goodbye. Thank you. Thank you.